IBD, part 6. So, picking up from biologics. So, these are the most specific class of medications, and their role is they're either going to be antibodies, which are going to bind up to receptor sites on your GI tract. So your white blood cells are no longer able to make things to bind to those receptor sites and attack them. Or if your white blood cells are making antibodies against your GI tract, these antibodies bind up the antibodies that your white blood cells make and render them useless. So they are very much specific in what they do. So at the top of the list, you're starting with your least specific anti-inflammatories. You get a little bit more specific, and finally you get something at the bottom of this list very specific to the IBD disease process. So goals of therapy is you want to use medications as long as possible, because if you do, you're avoiding surgery. And by doing so, if you control the inflammation, the patient's gut is normal, meaning they have good nutrition. So they've got good intake of protein, fats, and carbs. They've got good micronutrient nutrition. They're not bleeding, which means they don't have anemia. And you're reducing cell turnover, which means you're reducing the risk for colon cancer. And by the way, these patients get lots of screening endoscopies to see how their disease is doing. So they're being monitored with plenty of cameras and plenty of endoscopies and lots of wonderful places to monitor them for colon cancer and disease process. So if medications don't work, how about surgery? So in a pinch, in a patient with ulcerative colitis, surgery will work. Because it's just affecting the colon, if you take out the colon, you've removed the problem. Now, it's a big surgery, and you would prefer not to do it because you're giving the person some issues with their concentrating ability for their stool. They can't absorb the last 10 to 15% of their water, and they don't have as much capacity for stool storage, so they're going to go to the bathroom more frequently. And that's not a lot of fun. And because you've got to heal from a major gut wound, you're going to have the risk of surgical complications. But if you have to, it will work. You have no such guarantees with Crohn's disease. Why? If you take out the disease part of their bowel, wherever that is, you have no guarantee that the disease is not going to pop up before where you cut or after it. So, and plus, because you can get things like fistulas and ulcers that can happen where you made your surgical incision, you have no guarantees of anything actually working. Now, if their gut's doing so poorly, you absolutely can do surgery in a patient with Crohn's disease. I've seen it. But the risks, there's plenty of risks, and the risk-benefit ratio isn't that great. So you have no guarantees. It may or may not work. So your takeaways: you don't want to have either problem. You can predict what kind of problems you're going to have based upon the location of where the problem is in your gut: mouth, esophagus, stomach, small bowel, large bowel. Crohn's disease is by far worse to have than ulcerative colitis, but I am not trivializing ulcerative colitis in any way. Medication management, until your options have been exhausted. And then if push comes to shove, surgery will fix ulcerative colitis. You do not have that kind of option in a patient with Crohn's disease. Hopefully this exercise was helpful to you guys. I will do another one of these for your cases with acute pancreatitis. Sorry about having to cut these in 5-minute intervals. But it'll work. It's free. I don't have a lot of money to blow, and I will catch you guys at the next video. See you later. Stay healthy.